Hello, I'm Dr. Maury Markman from City of Hope, and I wanted to spend the next several sessions um, speaking about, I think, kind of a very interesting topic. I'll call it the evolution of precision cancer medicine. Long gone are the days when we would see editorials published that would make statements like precision medicine is an illusion, or would really question whether precision medicine has a role in standard of care management of patients with advanced disease or even early stage disease. We've evolved from a situation where there were very unique abnormalities, such as those that characterize CML, which of course led to the revolutionary change with the addition of imatinib, all the way to some of the errors with just making an assumption that all we need to do is find overexpression of a growth factor and target overexpression, and that would simply allow us to develop targeted therapies. Of course, we've learned that it's much more complicated than this, and obviously overexpression, rearrangements, mutations, all of this has become a very complex world. But the point is that precision medicine has now become truly the standard of care in the management of cancers. To the extent that a very interesting paper that just appeared in the Journal of Oncology Practice, looking at a very large health systems experience. Actually, this was with a pathologist-led ordering of the test. In over 3,200 patients who were looked at with advanced cancers, fully 49%, literally 1 out of 2 patients with advanced cancer, had, the words of the authors, at least one actionable genomic biomarker-driven, approved and or guideline recommended, targeted, or immunotherapy based upon the abnormalities, the tests that were done. So this has truly become standard of care. As a result, there are now questions that are being asked, some quite pragmatic, some really much more theoretical, based upon this paradigm change in the management of cancers that are coming to the fore. And what I'd like to do is to basically touch on a couple of these questions in the next several sessions. The first is, okay, if we make the assumption that we need to do this type of testing, when is the optimal timing? Should it be immediate diagnosis? At diagnosis, should it be later? Are there subgroups of patients who should be testing performed early and those later? Are there different kinds of tests that require immediate information? So we'll cover that in the next session. And then again, a little bit more of the theoretical comes up, and I'll talk about that near the end, and sort of highlight a very interesting observation about one of these questions. So thank you for your attention. I think this should be a couple of interesting sessions, and we're going to see many more of these types of questions that will come up in the future. And I look forward to talking to you at our next session. And thank you for your attention.